Differentiating between benign ECG variants and true pathology is one of the most important skills in clinical cardiology. In a high volume practice, misinterpreting a normal variant as pathology leads to unnecessary anxiety and testing, while missing a subtle pathological sign can be catastrophic. Here is a breakdown of the most common lookalikes encountered in clinical practice. Benign early repolarization, also called as early repolarization syndrome, is perhaps the most frequent mimic of an acute myocardial infarction. Comparing the morphology of ST, it is concave in early repolarization, while it usually is convex or straight or sometimes tombstoning in acute STEMI. J-point is notched or slurred, the fish hook-like appearance in early repolarization, while it is elevated without distinct notching in acute STEMI. STEMI is ST elevation myocardial infarction. Reciprocal changes are absent except in AVR in benign early repolarization, while it is present and probably highly specific for acute STEMI. T waves are large, symmetrical, concordant in early repolarization, while it is hyperacute or inverted in evolutionary phase of acute STEMI. The pattern remains stable over time, usually in benign early repolarization. It can sometimes disappear with exercise. Dynamic changes occur within minutes in acute STEMI. We will review the patterns once again in this early repolarization ECG. You can see the concave upwards ST segment elevation, notch at the J point, and you can see that there is ST depression minimal in AVR, which can be there in early repolarization. ST depression in AVR is equivalent to ST elevation in other leads. And you can see that T waves are large, symmetrical and concordant. Concordant means in the same direction as the dominant QRS deflection. This is an ST elevation myocardial infarction ECG. You can see the tombstoning pattern which has been marked with blue arrow, and J point elevated without distinct notching, and evolutionary change you can see inverted T waves because this is an evolved myocardial infarction or partially evolved rather than hyperacute phase. Here this is an inferior wall STEMI in hyperacute phase. You can see the upsloping ST elevation in inferior leads and reciprocal ST depression in other leads. It's present in lateral leads and even in anterior leads, extensive ST depression. If you see ST elevation in V2 to V5 with a notched J point and no reciprocal depression in the inferior leads, think benign early repolarization syndrome. If ST segment is convex and there is even 0.5 mm of depression in lead 3 or AVF, treat as STEMI until proven otherwise. Athletes often exhibit ECG changes that would be highly concerning in a sedentary patient. The International Criteria 2017 helped distinguish these. There are normal variants in athletes like sinus bradycardia, often less than 40 beats per minute, normal if asymptomatic, not in a person with syncope. First degree AV block is common in athletes due to high vagal tone. Incomplete right bundle branch block pattern is also common and does not by itself require additional workup. Early repolarization pattern with high voltage QRS and ST elevation can also be seen in athletes. But these are the red flags in athletes also. Deep T wave inversion in V4 to V6, 1 or AVL is a major red flag sign indicating probably hypertrophic cardiomyopathy. ST segment depression, never a normal variant in an athlete. Pathological Q waves with Q by R ratio more than or equal to 0.25, that is more than 1/4 of the ensuing R wave, or more than or equal to 40 milliseconds, that is 1 division at least in duration, in 2 or more contiguous leads, except lead 3 and AVR, where there could be normal Q waves, is suggestive of pathological Q waves. The saddleback or cord ST elevation in V1, V2 can be terrifying, but isn't always Brugada syndrome. In Brugada type 1, which is diagnostic, there is cord ST elevation more than 2 mm, followed by a negative T wave in V1, V2. This is diagnostic. This ECG, which is shown here, was sent to me by Professor Brugada himself for the inaugural issue of Indian Pacing and Electrophysiology Journal, which I initiated in 2001. This ECG also shows saddleback pattern in V3, ST elevation more than 2 mm, but with positive or biphasic T wave. This can be a normal variant or related to pectus excavatum. But as you can see in this ECG, it can also be present in Brugada syndrome. But it is not diagnostic by itself. In this ECG, you have both. But if this pattern is converted to type 1, that is the pattern seen in V1, V2, by drug challenge, like medications with flecainide, it is indicative of Brugada syndrome. Please note that drug challenge should be done only with great precaution, as it can rarely precipitate serious ventricular arrhythmias. T-wave inversions are quite common. When to worry or not to worry? Persistent juvenile pattern, that is T inversion in V1 to V3 in a young asymptomatic adult, more common in females. That is a normal variant. But on the other hand, Valence syndrome, deeply inverted or biphasic T in V2, V3, when the patient is free of chest pain, not during chest pain, this represents a critical LAD stenosis, a true pre-infarction state that has to be recognized, and early invasive management is suggested. Then there are cerebral T waves, massive, wide, deeply inverted T waves seen in intracranial hemorrhage or massive stroke. That is not truly originally a cardiac disease, but there can be associated non-ST elevation myocardial infarction, the old subendocardial infarction, or non-QA myocardial infarction can be there associated sometimes with cerebral catastrophes. Anyway, that is a different pattern.